This lecture is on peripheral nerve injury and its clinical applications. Much of what we will talk about you will have already discussed last semester in Bio 550 Human Anatomy. The sensory findings when there is a peripheral nerve injury will be an impairment in sensation in the distribution of the injured nerve. Sensation would be normal outside of the distribution of that injured nerve. For example, if we're talking about injury to the median nerve, we would expect to see impairment in sensation on the palmar side of the hand laterally, extending from the thenar eminence over to half of digit 4, and dorsally over the tips of the first 3.5 digits. But we would expect normal sensation over the hypothenar eminence, since this is innervated by the ulnar nerve. Similarly, motor findings should be limited to the muscles that are innervated by that particular injured peripheral nerve. This is a lower motor neuron disorder. We have damaged the alpha and gamma motor neurons, and damage to the alpha motor neuron means that acetylcholine will not be released at the neuromuscular junction. Failure to release acetylcholine at the neuromuscular junction promotes a rapid muscle atrophy. We'd also see a flaccid type of paresis or paralysis, depending on the extent of the nerve injury, and if this particular muscle is innervated by more than one nerve, and fibrillations and fasciculations. Fibrillations generally cannot be seen by the naked eye, but they are seen on EMG study. They are brief contractions of a single muscle fiber. However, fasciculations can be seen, and this is where you get brief contractions of single motor units. You may even experience fasciculations under normal circumstances. For example, if your eyelid twitches, or I know that if I have done a lot of writing and so my thenar muscles are becoming fatigued, I will sometimes get a fasciculations taking place in my abductor pollicis brevis muscle. We may see a reduced or absent deep tendon reflex as well as other reflexes, but the one that's typically tested on a clinical basis is the DTR, and this is because the lower motor neuron has been damaged. If you recall, this reflex involves sensory input from muscle spindles, the 1A afferent carrying information from the annulospiral ending. That 1A afferent directly synapses on our alpha motor neuron, which goes back and innervates the muscle fibers for that motor unit. So if we have damaged that alpha motor neuron, or also if we have damaged the 1A primary afferent from the muscle spindle, we're going to have lost our connection, our loop, our reflex arc. And as a result, when we test the reflex for muscle, it will be reduced if these muscles are innervated by the particular nerve that's been injured. Again, we would expect muscles that are innervated by other nerves to show normal function. You might recall from last semester that the sympathetic nervous system sends postganglionic sympathetic neurons to our limbs through the same spinal nerves that are carrying somatosensory and voluntary motor information. If we damage a nerve in the periphery, we will see autonomic signs related to damage to those sympathetic neurons. However, we tend to only see these signs if there are multiple nerves involved, or if there's complete transection of the nerve. So if you have a cut the nerve like we did last semester, then you would likely see these signs in the distribution of that nerve. If it is just a partial injury to that nerve, we may actually not see the sympathetic signs. Partly that's because the sympathetic neurons tend to be located deep within the nerve, so they're often spared when there's a partial injury that involves the more superficial portions of the nerve. But if we do see autonomic findings, they will include things like decreased or a lack of sweating in the distribution of the nerve. This can be a problem for temperature regulation, as sweating is a major mechanism we use to help us control our body temperature. Also, loss of vasoconstriction control. This can lead to edema and, again, impaired temperature regulation, because if you vasodilate, you're helping to, particularly in the skin, that is helping you to eliminate heat from the blood. And you may see color changes of the skin in the associated area. Other changes related to the sympathetic damage include trophic changes. These are things like shiny skin, brittle nails, thickening of the subcutaneous tissues. So when you are palpating, that the tissues feel really firm, much firmer than normal. There's an increased risk of skin ulcers, partly because you can have the edema and decreased blood flow and decreased oxygenation, and impairment of healing for these same reasons. There are a variety of different types of peripheral neuropathies. And they're basically named for the number of places where a nerve or a group of nerves is injured, and kind of the general symmetry and nature of the problem. So when you think neuropathy, think nerve pathology. That's really all that means. Mono means one. So mononeuropathy would be a single localized injury to a single nerve. Carpal tunnel syndrome or cubital tunnel syndrome at the elbow are probably two very common examples of mononeuropathies. So they're usually due to either compression or some kind of repeated mechanical stimulus, like a tool that is constantly pressing on the nerve. And so that causes a focal or a localized injury to that nerve, which oftentimes will lead to a conduction block, meaning that it doesn't generate action potentials, or propagate action potentials, I should say. So the cell body is generating action potentials, but they're only propagating to the point of injury, and they cannot propagate beyond that point. So you don't get your information being transmitted. Multiple mononeuropathy still means we're talking about focal injury, typically compression, but it's at more than one location. So you might have bilateral carpal tunnel syndrome, for instance, or you might have within a single limb, you can have compression at more than one location or involving more than one nerve. So maybe somebody has both the ulnar nerve and the median nerve affected in the upper extremity. Typically, we see an asymmetrical kind of pattern with the multiple mononeuropathies. Polyneuropathies, we're now talking about diffuse neurological damage. Typically, the symptoms are noted bilaterally and symmetrically. This condition is very common in diabetics, and we see a stocking and glove pattern where they have impairment in the feet and lower legs, the hands, maybe extending up into the wrist area. So we get this bilateral symmetrical type of presentation. Typically more pronounced distally than proximally, and it's usually more in the sensory than the motor signs. We believe it occurs distally more so than proximally because of the distance just having to travel, so there's more likely to be injury the further away you are, but also blood flow, and the you're further away from the heart. So blood flow, anything that affects microcirculation, like diabetes affects the microcirculation, is more likely to be problematic distally than it would be proximally, where you have larger blood vessels. We can then take the types of damage to the nerve and break that down further. Myelinopathy is where the axon is intact but you have demyelination. This usually resolves completely and quickly. Axonopathy, we've now damaged the axon itself. So again, looking at these words, just think about what they are telling you. They're a pathology of whatever the prefix is. So pathology of myelin. In this case, it's a pathology of the axon. So we have damage to the axon. So we typically will see good recovery, although it will be slow. And then we have severance, where you've actually, transected your nerve. And here you're going to get your degeneration of the axon and its myelin with slow recovery. And that's last unit where we drew that regeneration in the peripheral nerve. We're looking at from a severance where we have damaged both the axon and the myelin. With an axonopathy, actually, the myelin sheath may be intact, only the axon underneath it may be damaged. And finally, we have pathology involving the neuromuscular junction itself. We can have alterations in acetylcholine release. This is seen in that Lambert-Eaton syndrome. Again, Lambert-Eaton syndrome is a problem with calcium channels in the axon terminal. Since calcium doesn't get in a sufficient amount, we don't get as much movement of the synaptic vesicles to the presynaptic membrane for exocytosis, so there's too little acetylcholine that is released. And that's compared to altered acetylcholine receptors, basically either deformed or absent, or maybe even normal receptors that are then destroyed. So we have too few normal receptors that can respond to acetylcholine, and this is seen in myasthenia gravis. If we have loss of a peripheral nerve, we have loss of spontaneous acetylcholine release. So even though you're not generating action potentials, minute amounts of acetylcholine are being released from that particular nerve. This causes these little mini end plate potentials, they're called. Think of them as mini local potentials in the muscle cell. Not enough to cause the fiber to contract, but it does seem to have some type of a nutrient value to that muscle cell. We have loss of associated local potentials, both these mini ones, but also normal ones. And as a result, again, we get this impairment in the muscle health, and that leads to profound and rapid atrophy. So that's the end of our discussion on peripheral nerve injury. Now we're going to go ahead in the next set of lectures, move forward into injuries localized in the spinal cord.